All right, welcome to The Explainer. Today, we're going to dive into the incredible story of how the human body bounces back from an injury, and more importantly, how we as clinicians can guide that process. So let's get right to it, starting at the very beginning, the moment the body's alarm goes off. This is the question at the heart of everything we do, isn't it? What really goes on in that gap between the initial ouch and the moment someone gets back to doing what they love? It's definitely not a straight line. It's this complex, winding, and honestly, pretty amazing biological story. And we're going to walk through that story chapter by chapter.
So, Chapter 1. The story kicks off the very instant an injury happens. This first act is all about the body's immediate, incredibly powerful, and absolutely essential response to trauma.
And who's first on the scene? Inflammation. Now I know it gets a really bad rap, but it's not the villain of this story. Think of it more like the body's emergency services, the paramedics, the firefighters, all rushing in. Those classic signs you see, the redness, the heat, the swelling, the pain, and of course the loss of function, that's just the evidence that the emergency response is in full swing.
And this whole process is unbelievably fast and organized. I mean, within minutes, blood vessels in the area open up and get a little leaky. That allows fluid and proteins to flood in, which is what causes the swelling. And then, the first cellular responders, the neutrophils, show up. They literally roll along the inside of the blood vessel, stick to the wall, and then squeeze their way out into the tissue to start cleaning up the mess. It's like a perfectly coordinated biological rush hour.
But what happens if the damage is just too severe and some cells just can't be saved? Well, they die through a process called necrosis. Now, for us as clinicians, this is key. The way a cell dies tells a story. It leaves clues. Coagulative necrosis from a lack of blood flow in a heart attack looks totally different from the gooey, liquefactive necrosis you'd see in a brain abscess, or the weird, cheesy-like caseous necrosis from TB. Each pattern is a clue that points us toward the diagnosis. Okay, so that's the body's initial kind of chaotic response. The alarm is blaring. And this is where we, as clinicians, step onto the scene. This next part is all about how we manage that initial chaos to create the perfect environment for healing to begin. And this is a really critical question we have to ask ourselves. We can't just numb everything and pretend the problem isn't there. Our goal is to control pain in a way that lets the healing process do its thing and, this is the important part, allows the patient to start moving in a safe, therapeutic way.
A tool like TENS is a fantastic example of this targeted approach, because it's not just one thing, it's really two different tools in one box. On one hand, you can use a high frequency. This stimulates the big, fast nerve fibers and basically slams the gate shut on pain signals trying to get to the brain. That's our go-to for acute pain. But on the other hand, you can use a low frequency, which actually taps into the body's own natural pain relief system, triggering the release of endorphins. That's often a better fit for more chronic issues.
And then, of course, there's cryotherapy, good old icing. It's not just about making it cold. There's this predictable series of feelings the patient goes through, and we call it CBN. First, they feel an intense C-cold. Then it shifts to a strange burning or prickling feeling. That's followed by a deep, dull ache. And finally, numbness. That's our target. Knowing this sequence is great because we can tell our patients exactly what to expect, and it tells us exactly when we've hit our therapeutic goal.
Okay, so the crisis is under control. The body can now shift gears from emergency response mode into reconstruction mode. And this is where the really methodical, brilliant process of repair and rebuilding starts to take over.
What's so cool about this timeline is that it's not a set of rigid, separate stages. It's a beautifully overlapping process. So even while the inflammation and cleanup is still finishing, the body is already laying down new granulation tissue. It's like a fragile, temporary scaffolding. Then, starting around day 9, the real magic happens. That flimsy scaffold gets remodeled and replaced with stronger, more organized collagen, forming a mature, tough scar.
Now, our job is to make sure our therapy mirrors this biological timeline perfectly. We can't just jump into heavy lifting, right? We have to respect the tissue. So we start with passive range of motion, where we, the therapist, do all the work. Then we progress to active assisted, where the patient starts helping out a bit. And finally, we get to active range of motion, where they're moving all on their own. We're carefully matching our demands to what the tissue can actually handle.
And this really brings us to a core mantra in all of rehabilitation. You have to earn the right to progress to the next level. First, you get the motion back. Then, you teach the body how to control that new motion. After that, you build strength within that control. And only then do you get true function back. You just can't skip steps. And hey, if you hit a wall, it's okay. You just take one step back, master that, and then move forward again.
So once that foundation of motion and control is rock solid, we can finally start to build on it. This is where we shift into the really active phase of rehab, where our goal is to systematically and safely rebuild the patient's physical strength and capacity.
The foundation of all strengthening really comes down to one thing: the overload principle. It's so simple, yet so profound. Basically, tissues don't get stronger unless you challenge them. You have to ask the body to do just a little bit more than it's used to doing. That's what signals it to adapt and grow back stronger.
And right alongside that, you have the SAID principle. It stands for Specific Adaptation to Imposed Demands. It's just a fancy way of saying you get good at what you practice. So if your patient's goal is to be able to lift their grandchild off the floor, having them do a bunch of leg extensions on a machine is missing the point. We have to train that specific movement. The body adapts specifically to what we ask it to do, so we better be asking it to do the right things.
So how do we actually put all this together into a plan? We use a recipe, a framework called FIT-VP. This is our universal guide. We define the F frequency, the intensity, the time, and the type of exercise. Then we figure out the total volume. And most importantly, we have a clear plan for progression. This is what turns just doing some exercises into a systematic, safe, and truly effective program.
But here's the thing. Recovery is not just about tissues and exercises and frameworks. The final chapter of this story is about looking at the crucial psychological and systemic stuff that can honestly make or break a patient's entire journey.
This is the million-dollar question, isn't it? We've got the biological blueprint, we know the principles of training. So why isn't it always a smooth ride? Why do some patients thrive while others seem to get stuck? Well, the answer is because there's a complex, thinking, feeling human being attached to that injury.
This model is so helpful because it helps us understand where our patient is coming from. Someone in pre-contemplation, who doesn't even see a reason to change, needs a completely different conversation than someone in the action stage who is already doing their exercises. Our job is to figure out where they are on this ladder, meet them there, and help them take that next step up.
So how do we help them find that internal fire to keep going? Well, self-determination theory tells us there are 3 key ingredients. We have to foster their sense of autonomy by giving them choices. We need to build their feeling of competence by designing challenges they can actually succeed at. And we have to create relatedness by building a strong, trusting relationship. When you provide those 3 things, their own motivation starts to take over.
And this right here is a perfect example of where everything comes together. Say you have a patient who is on beta blockers. Well, that medicine is going to blunt their heart rate response, which means one of our main ways of measuring exercise intensity is now useless. We have to be smart enough to adapt, to use something like the rate of perceived exertion instead. This is about seeing the whole picture, their biology, their psychology, and their pharmacology.
And that really brings us to our final question. After walking through this entire journey, from a single cell sending out an alarm all the way to the psychology of human motivation, what do you think? Is our most powerful tool some fancy machine, a specific exercise, or is it a simple conversation? I think the answer is pretty clear. The first 2 are almost useless without the third. True healing happens when we combine the science of tissues with the art of human connection. Thanks for joining The Explainer.